All right, good afternoon or good morning. Welcome to our last science seminar for the semester. And we say the last for best. It's all about drugs. You guys need drugs, right? Caffeine, stay away, right? Hopefully not too much of it. Okay. So we have with us two representatives from a new pharmacy school in our region. This is big news. Not often that a new pharmacy school starts. And for all you pre-med, pre-health type people who might be interested in pharmacy school, it's good to know about these things. Also, it's good for all of us to know a little bit about pharmacology and talk about healthcare reform, all this other talk that's going on. It's good to know a little bit about drugs, where they come from, all that kind of stuff. So we have two representatives. They're going to tell us more about the pharmacy school and all kinds of other good stuff. And I want to remind you that we will have lunch with them. So if you're interested in applying to pharmacy school or something like that, just any pharmacy school in general, not just the UT Tyler Pharmacy School, but if you're interested in pharmacy school at all, or in drugs. Anybody interested in drugs? Yes. All right. You all come join us for lunch in the Joyce Room after the seminar talk today. Let's give our people one more.
My name is Andre Connor. I'm the graduate admissions representative for the College of Pharmacy. Today we have Dr. Wallace here. She's going to go over some information about careers and her type of career path. And then after that, if we have time, I'll kind of go over some slides about our program and kind of admissions requirements and things of that nature. So Dr. Wallace will take over.
All right, good morning, everybody.
Good morning.
I didn't realize that we were the last seminar of the semester, so that kind of puts pressure because I don't know if this will be as interesting to everybody, but hopefully we grasp the attention of a few of you that at least want to go into healthcare. Some people that are on the fence about it, maybe go ahead and get you over to the other side, some things like that. So first I want to see who I'm talking to in the room. So in terms of your majors, who are engineering majors? Oh, everybody. I know we're in the engineering building, but I wasn't sure. What about chemistry? Chemistry. What about biology? All right, biology. All right. Physics. Did you mention physics? Anybody else that I didn't mention? I'm leaving somebody out. Okay, so that's most of them. Huh? Nursing. Yay, nursing. Good. All right, we have a nursing school too, so nice. All right, so what I'm going to do today is basically talk about myself, which is probably one of the easiest things for people to do. But I felt like that was the best perspective to give to you guys, as I was a chemistry major in undergrad. So I'm going to talk to you about how some of your degrees, undergrad degrees, chemistry, biology, engineering, can drive you into health profession fields. And I'm just going to talk to you from my perspective, some of the research that I've done, and kind of my evolution to becoming a pharmacist. As Andre mentioned, I'm a pharmacist and I'm a clinical professor at the Ben and Macy Fish College of Pharmacy. So I teach and I see patients. So I do a little bit of both. So I get the best of both worlds, and I also still continue to do research. So as I said, I'll go through my journey a little bit. I'll try to be brief with everything, give you an overview of some of the things that I've done. And then I'll talk to you a little bit about pharmacy roles beyond the counter. Because I know most of you, when you think of pharmacy, unless you have someone in your family that's a pharmacist, you think about the person that's dispensing your medications at CVS or Walgreens or something. There are so many other pharmacists, types of pharmacists. It's just that the remainder of us are usually kind of behind the scenes. We're doing all the medication adjustments and making all the recommendations to the physicians without the patients even knowing about it a lot of times. So this is going to take you kind of beyond that. So for me, you'll see in the background, chemistry was my favorite class in high school. I decided I wanted to go to college and be a chemistry major, and I knew I wanted to go into pharmacy. I decided really young that I wanted to be a pharmacist, not really knowing why, except my aunt was a pharmacist. And I guess as I got older, I didn't really want to change my mind, so I just stuck with it. Decided to work at a pharmacy in high school, actually liked it. And then from there, my reasonings for wanting to become a pharmacist actually evolved into something that was more meaningful than just my aunt as a pharmacist. So I went to Tuskegee University. I majored in chemistry, got my degree there. And then from there, I went on to Auburn University, Harrison School of Pharmacy, which is only about a 15-minute drive up the road from Tuskegee, and got my degree, my Doctor of Pharmacy degree. So starting pharmacy school, I was kind of like most people. I knew retail. And I knew I liked research because I had done it in undergrad. So I was like, I'm going to do research, I'm going to do retail, and that's going to be my job. I'm going to work at a pharmacy. But then I got into pharmacy school, and I started finding out that I can see patients. I can go to a clinic and work there, sit down in a patient visit, discuss a patient's medication, and empower them to actually understand it. Because you can go home and talk to your aunts, your uncles, your parents, your grandparents, and ask them why they're taking certain medications. And it might surprise you that a lot of times they don't really understand the pathology of their disease state. They don't really understand the purpose of their medication. And sometimes you ask a patient, what are you taking for your blood pressure? And they report to you something that's not correct. So for me, being a primary care or ambulatory care pharmacist meant that I can empower patients to understand their medications. I can take a 30-minute visit and sit down and talk to them and help them to understand why they're taking these medications, instead of just going to that visit with the physician, picking up their prescription, and going home and just taking it because they were told to do so. So I wanted to do ambulatory care. And then, during my 4th year of pharmacy school, one of my professors was an ambulatory care pharmacist, but also she was a teacher. And I was like, I want to do that too. I love to mentor. I love to talk. I love to teach. So maybe I go into academia. And going into academia gives me the opportunity to teach. It gives me the opportunity to still see patients. And it also gives me the opportunity to do research, which was where I started, which is where everything started for me. So I get the opportunity to do all of those things as an academician, maintaining that ambulatory care pharmacist aspect. So here, why scholarship? This is just kind of coming from an academia standpoint, but in general, you all probably know this. Research is what drives our professions. So we continue to contribute to the literature that's out there, whether we're adding to something that's existing or doing investigational research, bringing something new to the table, but it's a necessary component. It's the same way in medicine. Breaking that down even more, it's the same way in pharmacy. So as a pharmacy professor, I do research, and I'm adding to what we already know a lot of times, or I'm gathering data to help to see how we can do things differently. So it's a very necessary component. So here I'm just going to go through very briefly, building on my foundation and what I did in terms of my research and how I got to kind of where I am now. So starting off in undergrad, I used to do a lot of what some people might call bench work research. So I started off as an undergraduate fellow, and my research was in breast cancer. So what I did was I saw some existing data on Caucasian breast cancer cell lines. We took African American breast cancer cell lines, and we treated them with inositol hexaphosphate to see what the viability of cell growth would be. So this was what I knew. I was like, this is chemistry, this is biology, this is everything wrapped into one. And I'm doing something that I love. It has to do with kind of medical field because we're treating breast cancer cells. And so this was the first big research project that I ever did. Going on from that, I went to work for Procter & Gamble. So I did 2 summer internships at P&G in Ohio. And this was very neat because, again, it was still kind of chemistry, so it was still dealing with my major, but it was very different from the breast cancer research that I had done. I was actually taking cow teeth, mixing together a bunch of ingredients to develop new types of toothpaste that aren't on the market yet, or they may be now, been gone for a while. But I wanted to see what...
in our toothpaste?
Huh?
There's cow teeth in our toothpaste?
No. He said there are cow teeth in our toothpaste. We use bovine teeth to test our products.
Oh.
Yeah. So we weren't using human teeth in the phases that I worked with. We used bovine teeth, and we would brush them with the different compounds that we came up with to see how well these novel toothpaste products would work. So this was probably one of my most fun times in my research development. I did this for 2 years, two consecutive summers. And again, while I was at Procter & Gamble, I sought out the PharmDs, the pharmacists. Once I found out that pharmacists worked for the company, I was like, wait, I want to do research. I want to be a pharmacist. I'm doing research. Pharmacists work here. How do I get in touch with them? And I met with maybe four pharmacists while I was there over the summer to see what it is that they did at a company like this. Because, again, like most people, I'm thinking retail, community pharmacy. That's all I know. So it kind of baffled me that there were pharmacists working for this corporation. But Procter & Gamble has a lot of pharmaceutical products that they sell and that the pharmacists contribute to in that way. moving on from that, when I was in pharmacy school, I kind of went back to a little bit of bench work, and here I was looking at atherosclerosis, so plaque buildup in your arteries. And we did this with mouse models, where we wanted to see how we could prevent or delay the development of plaque buildup in the arteries. And I was only there for a summer, so my involvement in it was minimal in the grand scheme of things, because it was just a 10-week summer internship, but it was very valuable for me because I got a chance to do certain things I hadn't done before, like Western blots, things like that, that I really didn't have as much exposure to in previous research projects. So again, it goes towards my medical desire, because I'm looking at atherosclerosis, and it also went towards my research desire. So I knew that this was an area that I could contribute to. And so the results there are non-disclosable, but we were finding some very good things with those mouse models. And that was at Indiana University, Purdue University in Indianapolis, Indiana. And so here's where I get into more clinical stuff. So those of you who want to go into nursing, into medical school, pharmacy school, anything like that, you start to get into more clinical research. So this is where everything kind of shifted for me from doing a lot of bench work to seeing outcomes for patients. And one of the first things I did was looking at chronic obstructive pulmonary disease, or COPD. It's a condition that prevents individuals from being able to breathe well. Usually it comes upon people that have smoked for years and years and years. And I wanted to see, based off our guidelines, which tell us how to treat a patient, are we treating patients appropriately in this hospital where I was currently working or as a student? Are we giving them the correct doses of their medications, including steroids that they get, inhalers that they get, and how well are they doing afterwards? So this was the first really clinical research project that I did, and I loved. So if medical field is something that you want to go into, it kind of shows you that you can do the bench work and then transition your way into kind of the clinical topics and still make an impact. So this one right here, we were able to go into the hospital and completely change the protocol and how they're treating patients based off the data that we got from this. So it's really neat. Other types of research, so teaching. If you think about, you guys are students now. How do we know that as professors what we're doing is impacting you? How do we know that you guys are gaining the knowledge that we want you to gain? What are your perspectives? How do you feel about it? So that's kind of where teaching research goes into play, and that's something kind of what I'm doing now. I want to know, especially as a new school of pharmacy, are the things that we're implementing in our classroom actually benefiting the students in the way that we think that it should? So that kind of goes into scholarship of teaching and learning. This particular project looked at residency programs, and so are residents able to help their residency program directors become more efficient in their work by helping them with their research? And we saw that, of course, the answer is yes. So if you have a resident that's there helping you do your research, you're able to open up to do more scholarship things in general. You're able to get through that data a little bit more efficiently, and you're able to publish those results a little bit more efficiently. So that's what this project showed. So again, I've gone from kind of developmental to outcomes research to teaching research. So moving into my first year of residency, testosterone use. So testosterone is something that we use, especially in men who have low testosterone levels, or who are having issues with producing testosterone. And in this, it was very similar to the other project with COPD, where I wanted to see in the VA system, how are we treating our patients that are on testosterone? Are we obtaining their levels? How do I know how much testosterone they're actually receiving? Is it enough? Are we checking it as often as we need to? So it's, again, one of those outcomes types of research where I wanted to see how much are we doing. And I saw that 88% of our patients were on a testosterone dose that was not endorsed by the prescribing criteria. So many of our patients weren't getting the correct doses, and 57% of those patients weren't getting their baseline levels. So it's one of those things where you can go in and educate our physicians about how to best use this medication, and when to best use it, how to monitor the levels, things like that. So I really like doing this type of research because it gives me an opportunity to make a very quick turnaround impact in patient care. These types of things don't take a lot of time it's called a retrospective review. So I looked back in the charts to see what the patients were doing, what the physicians were doing, and then from there I was able to implement a new protocol. Has anybody ever heard of Suboxone? Suboxone? So Suboxone is a medication that's used for, some physicians like to use it for pain, but it's mostly used for opioid dependence. So for patients that are on opioid prescription medications that are basically dependent on them, which most of you may know is a huge epidemic now. And so Suboxone is one of those medications that can help patients safely taper off those medications until they're no longer dependent on them. And so one of the things that I did at the VA where I worked as a resident was implementing a Suboxone clinic. It's something that many other VAs have, but to help our veterans that are basically dependent on opioid medications, hopefully taper off those medications and do so successfully. And so this wasn't really research in the sense that you think of it, but in terms of looking at implementing a program, following that program, and then determining what the outcomes are going to be, in that sense, you kind of look at it as a scholarly effort. And so we were able to implement some protocols, and since that was only 2 years ago when I was at the VA, they're still determining what the results of that will be, how many of our patients will actually impact from that Suboxone clinic. And then lastly, going into my second year of residency, very similar, PPIs. Has anybody ever heard of omeprazole? Prilosec. I'm like, do you guys walk in the pharmacy? Did you? Prilosec. So medications like Prilosec, people use all the time, more often than they probably should, for acid reflux. So one of the things that those medications can do is affect your magnesium levels. It can affect your bone health. It can cause infections if used long-term without being monitored. So one of the things I wanted to look at is how are we using these PPIs? How often are they being monitored? In patients with cardiovascular disease, it can cause issues for those patients long-term. So are we being proactive in looking at those high-risk patients to make sure that they aren't having any cardiovascular outcomes? So things like that to see if these patients were being monitored appropriately. And only 5% of patients that I looked at had magnesium levels that were being monitored. Of all the patients that I had, low magnesium levels can lead to cardiovascular detriment. Of course, cardiovascular detriment can lead to hospitalization, death, things like that. So we definitely want to make sure that our magnesium levels are being monitored. So again, this was one of those projects where I was able to quickly assess what was happening and then move forward and educate our physicians about what to do. And the very last one, to be honest with y'all, I did not like this project. This was one that, as a resident, those of you who are thinking of going to pharmacy school or medical school, residency is a part of that. It's becoming more and more a part of pharmacy, and it's a mandate in after medical school, you go into residency. And so sometimes you get projects that are necessary for the hospital that may not necessarily be your interest, but to be honest with you, I learned a lot from this project because my knowledge about cost analyses and management things and what all goes into inventory management wasn't very up to par. So it's a very informative experience, but definitely wasn't my favorite. So one of the things that we wanted to see was how much money we could save the hospital by switching patients' medications, essentially. So that you may know that there could be two medications that do the same thing, and one may cost more than the other. So can we save money by switching over to this other medication? And so what we found was that there could have been a potential cost savings of $140,000 per year. Just at me looking at a month's worth of data, I was able to extrapolate that. So the hospital was happy with me for that. The pharmacy department was happy with me for that. But I will continue to say that it wasn't one of my favorite projects. But it's still something that was necessary for the hospital system. And so, lastly, where am I now? So I mentioned that my specialty is primary care, ambulatory care. And what goes into that is a little bit of everything. So any chronic disease state that a person has, they go to their primary care physician. If they need a specialist like a cardiologist, a neurologist, nephrologists, then they branch off and go to those different specialty areas. So within ambulatory care, we're kind of a hodgepodge of a little bit of everything. We see all the patients, and then we can kind of send them wherever they need to go. So my interests are kind of the same, kind of a hodgepodge. I like a little bit of everything. So as I've transitioned into the role of becoming a faculty member in pharmacy, I wanted to make sure that I can continue to incorporate all those things that I love. And so some of the things that are down the pipeline for me in terms of research as a pharmacist are looking at cardiology and cardiovascular risk reduction. So patients with hypertension, patients with hyperlipidemia or dyslipidemia, which is DLD, diabetes, mellitus, and smoking cessation. So all of these things can lead to cardiovascular outcomes or in positive and negative ways depending on how you're treating the patient. And then medication use evaluation. So a lot of those projects that I just showed you where I looked at medication use and then implemented a protocol to help make the use of that medication better. Those are things that can be done all the time to help physicians, to help patients, and to help the healthcare system. Practice advancement. So health literacy is probably my biggest passion right now. If you think about it, you all in here are very educated, smart individuals. But how would your health literacy stand up to that? Health literacy is very different from general literacy. So you can have, it doesn't matter how many doctorate degrees you have, degree in engineering, somebody could come into the same clinic and walk out not knowing their medications. My sister's husband is an electrical engineer. He took my niece to the doctor the other day. He came home. My sister says, "What did the doctor say?" Something about she might need an antibiotic, but I don't think so. My sister's like, "No. What do you mean she might need an antibiotic?" So this is a very educated man. You know, he's got a master's in engineering, and he walked out of the doctor's office not knowing how to take care of his child. So she had to go online and look it up and call back. And most patients don't tell you that. And same way with him. Most patients aren't going to sit in there and say, "Well, I'm 60, but I don't read very well." Or, "I only have an 8th grade education," even though I'm expected to be able to read and understand what all these things that the physicians and the pharmacists and the nurses and the social workers are throwing at me. So health literacy is a big passion of mine, because if you understand what you're doing and why you're taking your medications, your health outcomes will be so much better. Understanding is the first step. So one of the things that I'm going to start doing in the community is going out and assessing the health literacy in East Texas and seeing how we can address that and how we can make that better. Because East Texas has some of the highest rates of infant mortality, deaths from lung cancer. I can't think of some of the other statistics, but we have some of the highest rates of those in the state of Texas. So that's big for me. Shared medical appointments. So has anybody ever seen an appointment with multiple patients in there at the same time? They all have diabetes. They're in that appointment together. The physician comes in, a nurse comes in, a pharmacist comes in, and they're all being treated at the same time. It's something that the VA system does a lot, and I feel like it really helps patients' outcomes, because the guys, especially with the veterans, it was mostly men that I saw, older men in the VA, they get competitive. They want to see their lab values go down each time they come in for an appointment. What's your level today? What's your level today? Oh, mine went down 2%. And so the shared medical appointments, because hearing about how to improve your health from somebody who has the same condition as you sometimes goes a little bit better than hearing it from your healthcare provider all the time, what you're supposed to do. So that's something I want to try to get started. And then interprofessional involvement. So people in here that want to go into medical school, I'm a pharmacist, we have people in here in nursing school. When you go into practice, all of these people work together. However, when we learn siloed. You have a school of nursing, a school of pharmacy, a school of medicine, school of psychology, social work. But then you throw us all in the hospital together, and we're supposed to just know how everybody works and how everybody learned and how to communicate with each other. So interprofessional involvement and starting that at the educational level is something else that I want to start to look into and research and see how we can improve that interprofessional relationship within this area. And then lastly, teaching and professionals. So do any of you do research with your professors now? A few people? Yeah. So how can we utilize students and residents in our practice settings? it's a big help for you guys because you get experience. It's probably something that you like to do. You can put it on your CV or your resume. It gives you skills, but it's also a big help for us because we get help, free help. Most of the time, sometimes you're in paid fellowships and things like that, but I've been a student and I've been a resident, so I've been on both sides of it, and I know that I offered up my help for free oftentimes because I knew that it would benefit me. Or as a resident, my help was offered without them telling me, and then I just had to do it because that's kind of how residency goes. So get ready for it, those of you who want to go into the medical field. And then team-based learning. So Andre may talk a little bit more about this. I'm not sure exactly what's all in his talk, but team-based learning is how we teach at UT Tyler, Ben and Fish College of Pharmacy. So you guys are used to lecturing, like I'm doing right now. I'm just standing up here and talking to you. And some of you are very engaged, and I can catch your eye contact, and I love that. And then some of you are eating, and some of you are falling asleep. And that's because, which is fine. It's fine. I don't take offense to it. You got a long day. But it's the lecture. So we're used to this lecture format. It's how I learned. It's how most schools function. At our College of Pharmacy, we don't lecture. We don't stand up here and talk at you or talk to you. We engage you. You're in teams because that's in the healthcare field. That's usually how you're going to work is in teams to some extent, and you solve problems. So I give you a patient case that's similar to something in real life, and you work with your team members to determine how to best provide care for that patient. And so I give you something to read ahead of time. You kind of prepare for class. You don't have to master it. You just have to kind of know it. And then you come to class prepared to utilize what you've learned at home and solve those problems in class. And so that's how the team-based learning pedagogy works. And so one of the things that a lot of the faculty in our school are doing is scholarship or research and looking at the outcomes in team-based learning classrooms. All right. And so here I just want to drive home to you guys. I know I've kind of just been talking about the research that I've done. But when you think about pharmacy, I know most people think about, like I said, the CVS pharmacist, Walgreens, somebody behind the counter that you have no idea what they're doing back there, but you know it's taking a long time for your prescription to get ready. They're doing a lot back there. But there are a lot of different other types of pharmacists. So as I mentioned, I'm ambulatory care. We have pharmacists that specialize in psychiatry, cardiology, infectious diseases, internal medicine. Pretty much anything you can specialize in as a physician, you can specialize in as a pharmacist. Nutrition, support, anything. So you can be a clinical pharmacist where you're making these types of interventions in your clinic or in your hospital, as well as be a community pharmacist. We have nuclear pharmacists, veterinary pharmacists, military pharmacists. So whatever your major is, whatever it is that you want to do, there's probably a place in pharmacy for you. All right, and this is the last slide that I have. I just wanted to talk to you guys about the places that you can go in pharmacy. And so many of you are getting your Bachelor's of Science right now in whatever your respective fields are. So going into pharmacy school, right now we don't have any joint programs at Ben and Fish College of Pharmacy. But the two that I have started here, the PhD and the MPH, Master's in Public Health, those are two that I think our dean is looking at down the pipeline. But if you think that you want to get a PhD, but you also might want to get a degree in pharmacy, there are programs out there that offer joint PhD, PharmD degrees. Or if you want to get a JD, we have a pharmacist that works for our College of Pharmacy who's a pharmacist and a lawyer. He teaches all of our law classes, and he also practices as a lawyer full-time. Master's in business, so if you want to get a business degree, but again, you think you might want to be a pharmacist, there are programs out there that have joint degrees that you could do that. I briefly mentioned residency training, so some of you may have heard of residency training, but essentially it's kind of a few years of you being a clinician and also still kind of a pseudo-student. So after you get your degree in pharmacy, your PharmD, your MD, whatever degree you go towards, you'll do a postdoc residency program. And that's meant to provide you with additional support while you're getting that more intensive clinical training. And so residency programs are becoming more and more a staple in pharmacy, and as I mentioned, they are mandatory in the medical field. because it shows that you're a specialist in your area and that you've gained that extra clinical knowledge beyond school. Fellowships are also available. So again, for those individuals who are very research oriented and want to do that, you can do a fellowship. You can go to pharmacy school and then complete a fellowship after that, so you can still specialize in whatever area of research you would like to. There are cardiology fellowships, infectious disease fellowships, many different types of fellowships that you can do if you want to maintain that more research focus. And then, as I mentioned, there are a ton of specialty areas. Critical care was one I didn't mention. Emergency department medicine is one. And then there are a ton of different types of pharmacists that you can be. So I know we're going to lunch. If people have questions about how your degree or your field can transition you into becoming a pharmacist, I'd be happy to answer those questions. It's one of the best professions ever to be a part of. I'm not biased about that. So if anybody has questions, please let me know. But that's all I have for you today. You have questions now before Andre comes up and talks about the Benamazee Fish College of Pharmacy?
Sure.
Yeah.
Questions from the audience before we go on to our next segment?
Somebody's pointing up.
I was just wondering about the Suboxone that you were talking about. My grandma is on fentanyl, and I'm just kind of worried about her because, like, every once in a while she kind of overdoses a little bit and gets real loopy. Would that be something that she could maybe work on, and would she still be able to manage her pain with the Suboxone?
Yeah, so the Suboxone probably wouldn't be good for her now because she's not necessarily addicted to the fentanyl. If she's taking too much of it, because that's the patch formulation, so they could go down on her patch if she's getting to the point where she's loopy or sedated or can't really function well because she's over-medicated. They can reduce the prescription amount in her fentanyl patch, but the Suboxone is more so for people who are seeking those drugs, people that have addiction to opioid medications. Not necessarily a tolerance, but a true addiction to the opioid medications that they're abusing them. And then they can use it. And most people that are abusing medications, they don't want to. It's just something that they can't stop doing at this point. So people that don't want to, but they can't stop, they can take Suboxone to help alleviate that. So it wouldn't really be the best option in her case.
Okay.
So you said the Suboxone or whatever can be off opioids, but can you get off those eventually, or are you like, once you're on those,
You can get off those eventually. So the protocols are usually very drawn out. It's not something that we rush patients into.
Yeah.
So it's a stepwise approach where we step you off the opioid very quickly. We do urine tests to make sure that you don't have any in your system. We bring you in, we give you the Suboxone, and that we'll give you a high dose, and then we'll say, hey, why don't you do a half a tablet less this week? If the patient can't handle that, we'll give them the full. But it's not the Suboxone. Some people say it's going from one evil to another, but the Suboxone is not as detrimental as the opioid addiction, and so we would rather slowly taper you off Suboxone, even if it takes us 2 years.
okay.
Yeah.
Would Suboxone be a proper replacement for methadone?
Yeah, methadone is another form of doing the same thing. So yeah, you can do either or. Okay.
There's the drug Nexium, which is the proton pump inhibitor, and there's articles that says it's linked to Alzheimer's in older patients. Do you have any information on that?
Yeah, so a lot of those articles are preliminary research. So what we do as pharmacists is we go in, we have patients that come in all the time and say those exact things. Like, I saw that it was linked to Alzheimer's disease. One, most of that is with long-term use, which long-term for PPIs is usually a year to 2 years is considered long-term because you're supposed to be on those medications for 6 weeks and then reassess and taper down to something a little less potent. But yes, they have been linked to some Alzheimer's disease with long-term use, just like the magnesium, just like the bone mineral density levels have gone down. So my advice to anybody that's taking them is if you can go down to something like a Zantac instead of a PPI, then do that. But yeah, you have people that are on it for a long time. And that data, like I said, is kind of preliminary, so we don't know if that's going to affect everybody or to what extent. But yeah, it has been linked to that.
So in general, who's responsible for this overprescription of drugs in America? Is it the doctor's fault? Is it the patient's fault for demanding something?
It's the health system's fault.
Health system's fault.
Because
no blame or all blame.
No blame, yeah. So you guys think about it. I mean, you have some patients that seek medications, of course, but some patients aren't. But we get these satisfaction surveys. How satisfied are you with your physician? Did they treat you the way you wanted to be treated? If you have a physician who doesn't want to prescribe a patient an opioid, and that patient says, I'm in pain, and he or she is saying, use Tylenol, use this, and they're like, no, I don't want to, then your scores are going to go down. Then that's going to reflect badly on the hospital. And so it gets to that point where you kind of do what the patient needs you to satisfy the patient. And that's not in every case, but in a lot of cases, unfortunately, it's like that, where you need to do what the patient says, this is what I need, this is what I want, I'm going to report you, whatever the case is. And so now one of the things that we're doing in terms of opioids is we're having pain contracts. So that's helping to alleviate a lot of that, where patients have to have urine tests to make sure that they actually have the medication in their urine and they're not selling it, or if they do anything, they can no longer get this medication. So it's more than just a verbal agreement now, it's an actual written contract between the patient and the physician.
So we have a little drug lab here in Longview that's all they do is test people's
Urine.
blood who are on prescriptions.
Mm-hmm.
So, yeah.
Yeah.
Okay, well, maybe we should move into our next
Yeah,
segment then
absolutely.
before we run out of time. If you have more questions about drugs and things, you can join in for lunch.
This
remember?
thing kind of falls off, so you got to hold on to the back.
Gotcha.
So, what's your favorite opioid? Dr. Fernand here? Okay, all right, back to
All right, so my presentation is not going to be as great as Dr. Wallace, but I just want to provide just some general information about our university, well, about our program in specifics. So I'm with the Benham A.T. Fish College of Pharmacy, the Office of Student Affairs. We have Dr. Sneller, who's our Associate Dean, so she's in charge of the whole admissions process. We have Patty Bell, who's our Student Affairs Coordinator. She works with all applicants, so once you were to apply to the program, then you'll receive emails from her. Then you have myself, just do all the recruiting and meeting with prospective students. And we also have Amanda Ritchie, who's our other Student Affairs Coordinator, and she works with all enrolled students. And we have Jared Sexton, who's our administrative assistant, who kind of runs our office. So some quick facts about our program. As mentioned earlier, we are a relatively new school of pharmacy. We started our first class in fall of 2015. So we're the 8th pharmacy school in Texas, although I did hear that University of Texas El Paso now has a pharmacy program. So there's 9 of us here in Texas. Our program is considered a 2+4 program. So 2 years for your prerequisite coursework, and then 4 years for the pharmacy doctorate degree. So basically, we don't require a bachelor's degree. But of course, if you want to finish your bachelor's degree and then go to pharmacy school, that's fine. It'll still take you 4 years, though, to finish the pharmacy doctor's degree. And also, too, we admit students every fall semester. So we're going to be admitting anywhere between 102 and 108 students. And the reason for that is because we teach exclusively as a team-based learning program, like Dr. Wallace mentioned earlier, which she really gave a really good synopsis of how it's taught. All right, so here's the minimum GPA requirements. You need a minimum 2.5 cumulative GPA, and that's for all the college courses that you take. So even if you take Calculus 1, you get a D in it, and you retake and you get an A, well, we're going to count the D in the A once we figure out your final GPA. We also require a minimum 2.5 for your science math GPA. And then we also require a PCAT, which is the Pharmacy College Admissions Test. However, though, we do not have a minimum score requirement. We just require that you take it as part of the application process. So here's a list of all of the prerequisite courses that we require. I also have brochures on that table over there, and I have a card stock that lists all of these courses. So on the left-hand side, you have all of the courses that you'll need to take for your prerequisites, and on the right side are the course numbers that you can take here at LeTourneau University to satisfy those requirements.
It's really nice of you.
Oh, yeah, we try to,
homework, huh?
yeah, we try to put it together. But yeah, so anyway, so all of those courses are required in order to come into the program. You don't have to have all of these courses completed before you apply. You just need to make sure that you finish them before you actually start in the program, right? In addition to those prerequisites, you also need to be Texas core curriculum complete. So if you are finishing a bachelor's degree before you come into our program, then you're exempt from the Texas core requirement. But if you're not finishing a bachelor's degree, then you need to also make sure that you take those general education courses. So like communications, art, history, government, social behavioral sciences. A lot of our prerequisite courses that we require can count twice. So they can count for our prerequisites, plus they can count towards the Texas core requirement. But if you're not sure about your Texas core requirement, you can always work with your advisor. You can always contact me, and we can look at your transcripts to kind of see where you're at. All right, so our program itself is a 4-year professional degree. So it's a full-time program. Classes are held Monday through Friday, 9 a.m. to 5 p.m. So the first 3 years, you'll have classroom work, and then with your lectures and labs. And then in addition to that, you'll also start clinic rotations. So we start our clinic rotations in the very first semester of the program, and that's where you go onto different sites. So like hospitals, CVS, Walgreens, Berkshire's, those type of sites. The 4th year is a full-time clinic rotation. So at this point, you're no longer on campus. You're just out in the field working 40 hours in a clinical setting, right, to get your clinical hours up. We do bring you back towards the end of the 4th year to help prepare you to sit for the national board exams to get licensed. So this basically just talks about our team-based learning. Dr. Wallace pretty much summed it up. But basically, once you were to come into our program, you'll be paired with 5 other classmates. So it'll be a total of 6 of you guys that will work together for an entire semester as a team. Once you get to your next semester, you'll be paired with 5 other classmates. So as you rotate throughout the first 3 years, pretty much we'll have an opportunity to interact with most of the people that you actually started with in your class. But on a day-to-day basis, like she said earlier, professors will provide you with reading material before class. Once you get in class, you'll have an individual assessment test that you take. You'll also have a team assessment test, which is pretty much the same test you just took by yourself. Now you're taking it as a team to come up with the best answers. There's also a lecture from the professor, usually no more than 15 minutes. But most of the time it's application exercises where they give you guys different case studies that you work on as a team to come up with different solutions. So far, students seem to like it. It is an adjustment for them, though, because it's not your typical way of learning. So they do have to figure out new ways to adapt to it, which they do. I think that's all I had. Oh, wow. Anyways, I had more than that. But, so to sum it up there, if you're interested in our program, basically our applications open up in mid-July, and they go all the way until March 1st of that next year. So, for example, the fall 2018 applications open up July 15th this summer, and it goes until March 1st next year, 2018. So what I recommend is applying early if you are interested, and then also make sure you take the PCAT, the Pharmacy College Admissions Test. Try to do as well as you can on it, even though we don't have a minimum score requirement. Try to do as well as you can go for that exam.
Questions on application process?
Or questions on team-based learning? Or
Some schools have, like, once you finish your 4th year, you get like a bachelor's of pharmaceutical science. So you have 2 years and you go there for 2 years, you don't have an intermediate degree you get?
Not at this time.
Okay.
At this time, we just have our PharmD program. I can foresee that happening in the future, but since we still are a new program, we're just focused specifically on our PharmD program at this point.
all right.
Oh, sure.
Who are the individuals that this pharmacy school is named after? They get a large
That's the question you asked.
donation to get started?
Yeah. So the pharmacy program is called the Ben and Métis Fish College of Pharmacy. So Dr. Ben and Mrs. Métis Fish, and Dr. Métis Fish actually, met at UT Austin in the 1940s for pharmacy school. So once they graduated, they got married. Eventually, Dr. Ben went on to medical school and became an allergist. And he opened up an allergist clinic here in East Texas. Since then, though, they have a foundation that donates money to different organizations. It just so happened that they donate a lot of money to our school, so therefore it's named after them. But yeah, it's a very well-known family here in East Texas that has a great foundation. And the building is actually called W.T. Brookshire Hall, so from Brookshire Grocery Company. So they also made a huge donation to us as well.
Any other questions out there?
All right.
All right, well then let's thank our speakers. I'll see you all next semester.
Grab brochures if you want them.
There are some brochures over there if you want to.
This thing fell off. off. You didn't feel it when you were talking?
Nah, I was holding it tight.
Okay.